We are going to get started. It is my great pleasure to introduce our speaker this morning, Whitney Gilley, who is here to give grand rounds. She has a degree in applied ethics and biology from Bellarmine University, did her medical school at University of Louisville, and is about to finish up her psychiatry residency here at ETSU. So without further ado, I will hand it over to Dr. Gilley.
Thank you. Welcome. So today we'll be talking about differing meditation experiences and their mental health implications. I don't have any financial disclosures. Meditation, including tranquility and mindfulness, have had a growing popularity in mental health fields, especially as a means to control and even treat affective disorders, addiction, and pain. These practices have only recently widely been adopted in the West, though often without the traditional cultural context. Many positive results have been seen with meditation practices, though certain techniques may not be right for everyone. Some may experience unwanted effects. We will be exploring differing responses today to better understand when and for who they can be beneficial for, and which practices may be less so. So what is meditation? Because of the wide variety of practices that are encompassed by this term, it is often misunderstood. Meditation is used in numerous ways, and what it means to practice meditation is often different between different traditions. Among researchers, there is a lack of sufficient criteria for a definition with widespread acceptance. A 2009 study by Bond and Ospina attempted to provide a more definitive definition of meditation, citing a persistent lack of consensus in the literature and a seeming intractability in defining meditation. They found 3 elements that were essential to any meditation practice: use of a defined technique, logic relaxation, and a self-induced state. However, many other criteria were found to be important, though not necessarily present in every definition, such as a state of relaxation or suspension of a logical thought process. Even if having had the experience of trying these methods, one difficulty in giving a definition is adequately expressing a very experiential process. Bojwang Waihai gave his student the koan of looking for the ox which is already beneath oneself. Many times when learning to meditate, people are still looking around for something, like something impressive is going to happen. Instead of recognizing these mind states are just there already, it's unseen and unnoticed beneath the veil of distraction. It is very helpful to think of meditation in terms of a tool or skill. The earliest written references to meditation were to yoga and yogi in the Vedic text of ancient India, some of the oldest scriptures found in Hinduism. In the early use of the word yoga, it referred to a skill, such as the skill needed to rope 2 horses together to your chariot. This is symbolic of conversion of the mind and the senses onto one target or goal. Zhuangzi gave another of the earliest descriptions of meditation, using the metaphor of the cicada catcher to describe a skill for completing a complex and difficult task. For our purpose today, we can think of meditation first as a tool or skill. In this context, we can add a functional definition from Walsh and Shapiro, where meditation refers to a family of self-regulation practices that focus on training attention and awareness in order to bring mental processes under greater voluntary control and thereby foster general mental well-being and development or specific capacities such as calm, clarity, and concentration. There are many forms of meditation. Some involve sitting quietly and produce a state of quiescence and restfulness. Some involve sitting quietly and produce a state of excitement and arousal. Depending on the type of meditation, the body may be active and moving or relatively motionless and passive. There is no specific classification system for these practices, but some groups can be used for the sake of simplicity. There are 2 general types of attention that we see, though in practice these forms often overlap. Concentration meditation is the continuous focus primarily on one object, such as the breath. Awareness or open meditation aim for fluid attention to multiple or successively chosen objects. Sometimes these are described in terms of a camera lens, with concentration meditation compared to the zoom lens, so looking at a specific point on the rock. Awareness or open meditation, sometimes referred to as mindfulness, may be described as the wide-angle lens, noting more generally the rocks and the sand. Techniques may involve switching between concentration and general awareness. Some practices encourage simply observing, such as non-judgmentally watching thoughts or images, while others deliberately modify them. The goal of a particular technique can be to foster general mental development and well-being, while others may focus more on developing a specific mental quality such as concentration or wisdom. The term mindfulness can encompass different things. Commonly in the West, it is understood in the way conceptualized by Jon Kabat-Zinn, who played a large part in popularizing this technique for mental health purposes. He describes mindfulness as awareness that emerges through paying attention on purpose in the present moment and non-judgmentally to the unfolding of experience moment by moment. There is a strong influence from Zen Buddhism's being in the present moment. However, it's important to note that in many Southern Buddhist traditions, mindfulness actually refers to keeping something in mind, bringing an awareness of certain concepts, such as impermanence, to the present moment. They would refer to the other definition of mindfulness as simply awareness or alertness. In either definition, the mindfulness can be external or internal, focused on emotional states or thoughts. Concentration meditation develops focus on a specific object, such as a candle flame or the breath. This is often what people are picturing when they think of meditation. Concentration involves various degrees or depth. Anything can be a focus of meditation, though not all objects of concentration are intended to create really deep states. There are many forms of concentration meditation. Using the breath is common, but in both concentration and mindfulness techniques. It has considerable overlap at times. Mantra recitation is the repetition over and over of a word or sound to aid in concentration, and this is practiced worldwide. Well-known examples are the use of Om in Hinduism and Om Mani Padme Hum in Tibetan Buddhism. Malas or prayer beads are also used worldwide to count repetitions of mantras, prayers, or breaths. Loving-kindness meditation is another form which cultivates a positive mood or beneficent outlook through the contemplation of these feelings for all people and beings. Visualization is another concentration technique that generates a mental image and may or may not require an external subject to elicit the image. Subjects can range from internal visualization of a specific color to external focus on a geometric design or elaborate mandala. Here are examples of Tibetan Thangka depicting a deity and a Kala Chakra mandala. Movement meditation heightens awareness of the sensations of movement and involve physical movement to a greater or lesser degree. Sometimes this results in a state of excitement, sometimes a state of relaxation. Examples include walking meditation, Tai Chi, Hatha Yoga, Isaguro Zen, Sufi whirling dervish, and certain tribal trance dances. The presence of meditation across many cultures is likely related to its ancient origins. The earliest potential record of meditation appears on Harappan seals from the Indus Valley. But meditation is actually believed to predate civilization. Studies based mostly on extant tribal societies suggest that meditation techniques may have developed from looking into the flames of fires. Chanting may also be one of the oldest forms. Rosano proposed an interesting correlation between the emergence of symbolic thinking in early humans with the altered states of shamanistic healing practices. Use of altered states in this way may have led to improved fitness and health, promoting Baldwinian selection and increasing capacity for attention, memory, and overall cognitive capacity. This may be why humans, including everyone here, possess the innate ability to enter into these altered states. Meditation is found worldwide in most cultures and in every major religion. We won't go through every one. For example, there are many forms of secular meditation, which has had growing popularity in the United States and Europe. We also know that forms of meditation were being practiced in ancient Greece. All the Abrahamic religions mention contemplation or meditation in their sacred texts, and many forms of meditation are still practiced today, as listed here. There are many Native American traditions in both North and South America that incorporate meditation. These are very diverse and vary between tribes and sometimes family groups, but can include chanting or movement meditations as well as many other forms. Many cultures in Africa employ meditation. Among the most famous is a tribe of San people in the African Kalahari Desert, whose name I'm not able to pronounce, but they're known for a form of movement meditation where the participant engages in a certain type of dance to induce an altered state. And these are pictured up there in the photo in the rock painting. The more widely forms of meditation that we tend to think of include Taoist meditations and Hindu yogas, as well as diverse Buddhist meditation traditions. In the introduction to the book, The Physical and Psychological Effects of Meditation, Eugene Taylor noted, to refer only to meditation from a particular faith, such as Hindu or Buddhist, is not enough, since the cultural traditions from which a particular kind of meditation comes are quite different, and even within a single tradition differ in complex ways. The specific name of a school or school of thought, or a teacher, or the title of a specific text is often quite important in identifying a particular type of meditation. Eastern techniques were introduced into the West through gurus such as Swami Vivekananda, who introduced yoga and meditation in the United States in the early 20th century, and then Yogananda, who further popularized these techniques in the 1930s. Secularized variants of yoga traditions emerged, including transcendental meditation and numerous forms of hatha yoga, which became known simply as yoga in Western terminology. Meditation's popularity in the West was in large part spurred by the Beatles, after they took up transcendental meditation in the mid-1960s. Here they're pictured with the founder of transcendental meditation, Maharishi Mahesh Yogi. And here we also have a quote from George Harrison talking about his quest for a mantra. Transcendental meditation was derived from Hindu techniques and philosophy, but was promoted on the possibilities of self-improvement by engaging in a simple practice of reciting a mantra for 20 minutes twice a day. The popularity of this technique took off in the 1960s and early 1970s. Scientists became interested, and research investigating the medicalization of meditation began in earnest in the 1970s. TM's popularity waned after 1977, when advertisements promising levitation and other supernormal powers were promoted. Scientific studies on meditation, however, would continue. The past 30 years have shown significant increase in mainstream interest in mindfulness meditation. It has been researched and evaluated with promising results in a wide variety of areas. Publications have increased from almost none in 1980 to 773 in 2014. And from what I can tell, this uptrend is continuing. The benefits have come to the attention of educators, and now mindfulness is being incorporated as a part of a curriculum in schools coast to coast. Based on research indicating it can help improve cognitive abilities such as attention, memory, and executive function, which might translate into better academic performance and also behavior. Mindfulness may also reduce test anxiety, increase resiliency, and creative thinking, according to some research. Many hospitals are implementing programs to teach mindfulness techniques to staff to prevent burnout. Businesses, too, have taken notice of studies indicating mindfulness that can improve job performance and also productivity. The military has explored uses to improve soldier skills and resiliency. Some research has shown mindfulness could improve your sports ability, such as basketball throws. It has also been marketed to the general public as a way to improve your sex life, though this was certainly never the intended use of the mindfulness techniques in the tradition from which they were originally derived. Here's a list of some of the clinical uses that have been studied to varying degrees. From this, there is a feel that mindfulness is becoming a panacea. According to the most recent cross-sectional study performed by the NIH in 2012, 8% of U.S. adults have practiced some form of meditation within the past 12 months. So that's 2 out of 25 Americans engaging in these practices. A similar study from the same year showed 1.6% of American children also were engaging in meditation practice within the past 6 months. Some practices that can involve meditation, though may not have been recognized as such by participants, have also been steadily growing. In 2012, for example, 9.5% of U.S. adults were practicing yoga, up from 6.1% in 2007 and 5.1% in 2002. Patients are encountering these techniques not only in peer groups or in religious contexts, but also marketing and other media. Instructions for even advanced meditation practices are easily accessed in print and on the web, when at one time such instructions could only have come from a meditation teacher. Intensive meditation retreats are available in most states and in a wide variety of frameworks, traditional and otherwise. It is interesting to note that some retreats screen participants beforehand and deny admittance to those who had acknowledged a history of mental illness. The use of meditation techniques for treatment of mental disorders really began in the 1950s and early 1960s when Suzuki attempted to adapt aspects of Zen Buddhism to the new existential psychoanalytic forms. Suzuki was a Zen teacher well known in the West and influential to the beat poets as well as some analysts, such as Erich Fromm, Karen Horney, and Harold Kellman. In the 1930s, he persuaded Carl Jung to write the foreword to his book, Introduction to Zen Buddhism. Western clinicians, Jung said, should admire but not attempt to integrate these practices into their work. More common evaluations have described meditation as being characterized by adaptive as opposed to psychotic regression, during which intellectual defenses are suspended. Repressed or incompletely processed material from the subconscious may then be released or perhaps unleashed in meditation. In that state, emotions experienced cannot be disowned or transferred. Hence, it has been considered a possible tool for gaining access to material which is at a low level of cognitive awareness or unconscious. Goleman argued that slow-paced exposure to unpleasant memories during the relaxed state of meditation could be used for desensitization to trauma, though through reciprocal inhibition. Meditation had been shown by Herbert Benson to reduce physiologic signs of stress. Of course, meditation may not always be relaxing for all people. Adding to the complexity is the assumption that the material being brought up in meditation for psychotherapy could be metered. It's unclear if this is a realistic expectation. Psychiatrist Claudio Ornstein suggested that meditation facilitates insight into how one processes and constructs their reality. With increasing awareness of constructs, one moves from a pre-verbal construing to the level of symbolism. Like scientists experimenting with their own experience of themselves in the world, meditators become engaged in a reflexive exploration of their own sense-making equipment. Loosening of constructs that occurs with meditation has been noted to create a type of resiliency or elasticity, and possibly plasticity of cognition. The increasing of awareness of elements that were previously excluded, such as formerly repressed emotion or memory, may then have an opportunity to be addressed. New connections can be uncovered in a nonlinear processing of information. However, this sort of destabilization with the goal of a deeper stability may require significant strength on the part of the patient as well as the meditation practitioner. Albert Ellis, one of the founders of CBT, argued that the use of meditation in therapy should only be for thought distracting or as a relaxation technique. He went on to compare meditation to tranquilizers and stated meditation could be harmful for patients by encouraging them to avoid their central problems. Another key figure in the development of CBT, Arnold Lazarus, argued that meditation wasn't for everyone, after noting some of his patients had serious reactions after practicing it. Since the 1970s, there have been a number of researchers and therapists looking to incorporate meditation techniques into mental health treatment. Mindfulness techniques have become more prominently incorporated in the last 30 years or so, beginning with the pioneering work of Jon Kabat-Zinn and the development of MBSR. Here's a list, though not exhaustive, of therapies that draw from meditation techniques. I won't go into detail about these, as Dr. Tennyson covered most of these in nice detail last month, and we had a great presentation from Dr. Culligan on MBCT just last week. And I think these talks are available online if anybody's interested in those. There is an enormous amount of published research on the benefits of meditation, and it would not be possible to do justice to that body of information in an hour. However, I would like to point out some studies before we move into an area that is less well known in meditation research. In 2004, a meta-analysis on mindfulness-based stress reduction examined studies in a wide range of patient populations and reported that patients appeared to benefit from this therapy. Hoffman et al. Performed a meta-analysis on mindfulness-based therapy for depression and anxiety and noticed robust effect sizes correlating with improvements in affective symptoms in patients with anxiety and mood disorders. In 2014, Goyle et al. Published a meta-analysis in JAMA Internal Medicine showing moderate improvements in affective symptoms, stress, pain, and overall quality of life in meditators, though the results were more modest. Another really interesting study to note that I think had been mentioned in prior grand rounds compared the effectiveness of mindfulness-based cognitive therapy to maintenance antidepressant treatment. What was interesting is that it found that patients did no better or worse with MBCT or antidepressant treatment in prevention of depression relapse. Richard Davidson, a well-known meditation researcher, remarked that even short-term practice can be beneficial. A 2014 Harvard study with 16 participants examined subjects using MRI 2 weeks before and again after an 8-week mindfulness-based stress reduction program. On average, they practiced 27 minutes of mindfulness each day. A control group of non-meditators had MRIs performed and repeated over the same time interval. Gray matter increase was noted in the areas associated with memory and emotion. The images identify gray matter concentration increases in the left hippocampus in the MBSR group. Here we see increase in gray matter concentration in the MBSR group from pre to post in the exploratory whole brain analysis. A shows a cluster in the posterior cingulate cortex and cerebellum, and B a cluster in the left temporal parietal junction with peak in the middle temporal gyrus. And then in C, we see a cluster in the cerebellum and brainstem. In another study, 2 weeks of compassion-based meditation led to more altruistic behavior among study participants that took place in a monetary redistribution game. There were correlative differences seen on fMRI when comparing compassion-focused meditators to the control group. Figure 1 shows the blood oxygen-dependent changes in meditators after viewing images of suffering and then performing emotional regulation. There was activation in the right inferior parietal cortex and right dorsolateral prefrontal cortex. The color coding indicates the amount of variance accounted for by the group versus the control interaction. Figure 2 shows the connectivity between the right dorsolateral prefrontal cortex and the nucleus accumbens, so A and B respectively. There are a number of studies indicating morphometric changes in meditation and seem to suggest there's actually some differences between types of meditation and the results that you get. I won't go into these studies, but full references are available for anybody that's really interested. There has been an extensive amount of research into the benefits of meditation techniques, including cardiac, respiratory, and immune benefits that we won't be able to go into today. There's not been so much research in potential side effects or contraindications, in part because of ethical concerns, but likely also due to the popular perception that such techniques are generally harmless and mild. But what treatment carries no risk? With the notable effects seen in imaging and physiology of meditators, how could it be that there would never be, at times, undesired results? There is not necessarily a typical meditation experience, and starting out, a meditator may not notice anything different at all. We commonly associate meditative states with relaxation and decreased anxiety that makes it for a great stress reduction. However, some meditators will describe feeling more alert, kind of keyed up, speeding up, exhilaration, and even euphoria. When practicing a meditation technique for an extended period, there may be a wide variety of experiences even within the same session, pleasant or unpleasant. More common examples include anxiety, mild dissociation, and feelings of guilt. It is not uncommon for people to cry when they meditate. Uncomfortable kinesthetic sensations can come up as you become more aware of the body, and suddenly you start to notice there's a lot more pains and itches than you ever noticed before. You may also feel hot or cold, but this can become more extreme with sensations of burning or electric shock sensations. Some may experience nausea due to rapid increase in parasympathetic activity. Meditators may also experience perceptions of dissolution and vibrations, and sometimes internal images and sounds can arise. Many traditions describe stages or patterns of progression that meditators using their method go through. Examples include Vipassana, a type of meditation used in Theravada Buddhism, which recognizes 16 stages of meditation development, which we will revisit later. The Sufi stages of Muraqabah, which are broadly characterized, though they can merge and actually overlap with one another. And then there's also the well-known stages that are described by St. Teresa. There is some overlap between traditions' stages, but significant differences exist dependent on the particular technique used. Many of these descriptions include a period of difficulty, but not all of them. St. Teresa de Avila was a prominent Spanish Carmelite nun and Roman Catholic saint that practiced meditation, contemplative prayer. She describes stages of her meditation in her autobiography, The Four Stages The fourth stage, called devotion of ecstasy, describes a state characterized by both ecstasy and pain. Imagery of St. Teresa often depicts her with an arrow through the heart, reflecting this experience. Here we see images of her in a state of meditative bliss, with pain close by, depicted by the angels with arrows. Few studies have addressed possible downsides of meditation practice, particularly in community populations. Psychologist Tim Lowness and his associates conducted in-depth interviews with 30 male meditators, including mindfulness, in London, who had been practicing for non-clinical reasons. Most subjects reported benefit, finding it conducive to well-being. However, they also noted a fourth of the interview data was on substantial difficulties these meditators had encountered, including challenging experiences of the self and frightening dissolution of identity. For some, mindfulness made them aware of their distress, but unable to deal with it. So they found that meditation was not only unhelpful, but counterproductive. Four main problems encountered in meditation were seen in this study. Meditation was a difficult skill. Participants encountered troubling thoughts and feelings which are hard to manage. Meditation reportedly exacerbated some mental health issues such as depression and anxiety, and in a few cases, meditation was associated with psychotic episodes. Focusing awareness on thoughts and feelings is often a demanding cognitive exercise. Mindfulness for 20 minutes a day resulted in high levels of biologic stress as measured by higher levels of cortisol, despite lower reported levels of subjective stress than in those in the non-meditation control group. Experience of intrusive thoughts and feelings is not uncommon in many types of meditation, as the therapists in the 1960s and 70s noted. Swami Ambikaనంద and Saraswati, a meditation teacher and translator of Hindu sacred text, explained that when you meditate, the scum rises to the surface, and that most meditation teachers know this, but they don't like to discuss the intrusive thoughts and feelings, such as sexual, sad, fearful, or violent ones that may arise abruptly when you meditate. This is a painting of a well-known scene described in the Pali Canon, where the Buddha, meditating under the Bodhi tree, was tempted by Sylvan Devas and Mara's daughters. Many people believe this description in Buddhist text refers to the struggle with lust that can take the form of unwanted, overtly sexual images and thoughts arising in meditation. In 1992, Shapiro found that 62.9% of his subjects reported adverse effects during and after meditation, and 7.4% experienced profoundly adverse effects. Length of practice from 16 to 105 months did not make any difference. The recorded effects included increased anxiety, tension, and panic, decreased motivation, boredom, physical pain, impairment in reality testing, confusion, and disorientation. We don't know if meditation, for whatever reason, can trigger major psychiatric symptoms in people who are otherwise healthy and may not otherwise have experienced such problems. In case report, we do have documentation of individuals who had no known prior psychiatric history presenting after practicing meditation, but I will point out this is usually intensely. Some of these individuals may have had predisposition to developing schizophrenia, such as the 20-year-old man described in Sethi 2003. Others may represent what are called culture-bound syndromes, such as the case in Shu 1994, where we are seeing these brief psychotic reactions globally outside of cultures that traditionally recognize them. So is it safe? The National Center for Complementary and Alternative Medicine includes disclaimers on their website. It says that meditation is considered safe for healthy people, but there have been rare reports that meditation could cause or worsen symptoms in people with certain psychiatric problems, like anxiety and depression. People with existing mental health conditions should speak with their healthcare providers, so they're going to come ask you about this, before starting a meditation practice, and make their meditation instructor aware of their condition. In 1977, the APA called for more research on contraindications and dangers of meditation techniques. We still don't have much of this. Willoughby Britton, a researcher with Brown University, became interested in studying the differing effects of meditation practices after having an experience herself, as well as seeing some in a clinical setting. She founded the Cheetah House as a place for contemplative study collaboration. She and her team have been studying adverse effects in difficult stages, also referred to as the Dark Night Study, which focuses on meditators with more severe and chronic undesired effects from meditation. Interviewing teachers, religious scholars, and meditators, they documented individuals struggling with significant impairments, meaning having to take off work for a month or more, unable to care for children, and even requiring inpatient psychiatric treatment. They have noted that the average amount of time these meditators experienced difficulties was between 4 months to a decade, with an average duration of about 3 years. Unfortunately, the full study hadn't been published from the time I was preparing this talk. Walsh and Shapiro noted, in their traditional settings, meditation practices are usually embedded in supportive lifestyles, such as ethics, and practices designed to optimize their development. American meditators are often utilizing meditation outside these settings. Dr. John McCransky, a Boston College professor of theology, has also raised concerns about the loss of protection from the collective compassion of a group, such as the Sangha in Buddhist practice, when meditation is taught in the West. Teachers not only provide support in times of difficulty, but often start to guide and warn students appropriately. And just as important, they may emphasize that certain experiences don't necessarily equate with meditation going wrong, providing a missing context for difficult experiences. This can be especially true if meditators are encountering difficulties in esoteric practices that clinicians are going to be less familiar with. Some meditation techniques are designed for particular types of people, different personalities, and would not traditionally be given or recommended to others or only at certain times. The Dalai Lama commented that Westerners who get deeply involved with meditation should note the existing body of wisdom in these traditions. Otherwise, certain physical or mental difficulties appear. Guidance and support, whether from a teacher or group, is something that is recommended in most traditions. The consensus among Sufi scholars is that the seeker cannot self-diagnose and that it can be extremely harmful to undertake any of these practices alone. Hindu saint Ramakrishna compared how a young tree planted on the footpath needs a fence around it for protection, just as a beginner needs the supportive community of the satsang. The removal of supporting traditions to create a marketable secular practice for use in ways these techniques were not designed has raised concerns about unknown risks. One researcher described, at issue is often less whether or not these practices work, but more whether there is a danger in dissociating them from the ethical framework from which they were originally developed. Mindfulness, the argument goes, was never supposed to be about weight loss, better sex, helping children perform better in school, helping employees be more productive in the workplace, or even improving the functioning of anxious or depressed people. It was not designed to create optimal warriors. In one study, British inmates at 7 prisons took weekly 90-minute classes in Hatha Yoga that included 10 to 20 minutes of breathing meditation, and then completed tests to measure their higher cognitive functions versus a control group in a 10-week randomized control trial. The prisoners' moods improved, and their stress and psychological distress reduced. However, they were found to be just as aggressive as before they started meditating. In 2013, a 34-year-old man known to be a regular meditator shot and killed 12 people at the Washington Navy Yard where he was working as a subcontractor. He was a former Navy reservist with reported history of violent crime and PTSD symptoms from assisting with the 9/11 recovery efforts. At the time of the shooting, witnesses described him as being paranoid and delusional. Meditation as a tool in of itself does not create morality or wisdom. Torkel Brekke of the University of Oslo in Norway describes traditional texts that explain how individuals through meditative practice may act amorally if their actions are undertaken in a detached state of mind. Rather than being exceptional, the association between meditation and detached killing became the norm in Japan during the Second World War. Brian Victoria, a historian and Zen priest, writes about how the training of Japanese soldiers included the use of meditation techniques to ensure that the soldier suppressed his sense of self to become the very order he received. Teachings on emptiness have long been used to justify certain acts of violence as having no karma. We see this kind of thinking in Takuan's poem, where he describes that there is no one wielding the sword. Practice of meditation in virtually all major forms across traditions can lead to experiences where the meditator confronts their very sense of self. Various and Wilcombe describe the purpose of meditation as radical, to challenge and rupture the idea of who you are, shaking one's sense of self to the core so that you realize there's nothing there or no real differentiation between you and the rest of the universe. In the Abrahamic traditions, there's a focus on letting go of that self to allow in the divine, sometimes termed mystical union or union with God. In Sufi Islam, for example, there's a practice towards fana, the passing away of the self, where the consciousness that remains would be considered the divine within the human. Put another way, by Del Monte, the final goal of meditation is to transcend the ego in the Jungian sense. The advanced meditator is trying to break down the very barriers erected to demarcate self and non-self. Wellwood suggested that ultimately the goal of psychotherapy is often to strengthen the ego, but the meditation techniques are used for transcending ego. It may be that meditation is most helpful for people who already have an adequate level of personality organization. Ram Dass noted that confronting our own very intimate views of self in meditation can be frightening. He stated, if you start to use a method that makes gaps in the web of thoughts of who you are and what reality is, might you not get frightened as the comforting walls of the ego start to crumble? You might at that point pull back towards the familiarity of your pain. Meditation teacher Shinzen Young stated that almost everyone who gets anywhere with meditation will pass through periods of negative emotion, confusion, and disorientation. The same can happen in psychotherapy and other growth modalities, but in Zen, for example, this is termed falling into the pit of the void. And it entails an authentic and irreversible insight into emptiness and no self. But instead of being empowering and fulfilling, it turns into the opposite. He describes this as serious but still manageable through intensive guidance under a competent teacher. In some cases, it takes months or even years to fully metabolize, but he states that in his experience, the results are almost always highly positive. As we saw before, meditation has been described as releasing of hidden memories and themes from the past, which can include childhood trauma, rejection, and abandonment. One meditator in Loma's 2015 study described painful emotions related to childhood trauma emerging with meditation. He says, I saw the depth of the pain that is buried, things that have not been dealt with properly. It can be very scary. Another meditator described, at first I wanted to deny the fear in my usual fashion, but feeling a center of inner serenity with meditation, I let myself go. It was devastating. I felt lost and abandoned forever. I could continue to sit and watch my fears until the pain gradually dissolved. Experiencing and not reacting or running away was a new experience for me. Some meditators describe reemergence of grief. One described difficulties with a particular type of meditation, loving kindness, finding it painful. He states that with this meditation, I always experience very strong emotions and I don't always have the awareness and robustness to deal with those. Another meditator stated that during mindfulness and meditation, he often became aware of aspects of himself that he didn't like, which then fed negative thought process. Meditation can enhance perception and cognition, leading to a heightened emotional state. Del Monte suggests that relatively neurotic or anxious subjects may be confronted with emerging cathartic material at a pace they can't cope with, and therefore may not find meditation very rewarding. Fear is one of the most common unpleasant experiences during meditation. Some describe this as a response to the sense of impending loss of their system structure with loosening of constructs, or put in another way, anxiety at losing sense of self. Paradoxical responses to relaxation have been noted in the literature with far less intense meditation practices. There have been some research showing correlation with meditation and increased whole blood serotonin levels, suggesting a possible neurochemical explanation for this paradoxical anxiety. Many meditative traditions comment on periods of anxiety and fear, referred to as a great terror in the Visuddhimagga and great doubt in Zen. Forcing meditation has also been known to increase anxiety and is cautioned about in a number of traditions, such as Suklung in Tibetan medical theory, while contemplating too strenuously has been seen as contributing to Zen illness. Some have hypothesized that overexertion in meditation may account for some of the cases of paradoxical anxiety reported in TM. Vipassana, also called insight meditation, is a form of analytic mindfulness meditation where the meditator watches the movement of breath in the abdomen. It originated in Burma and was widely popularized by S.N. Goenka. This tradition has a well-defined roadmap that includes a period of difficulty midway through the practice that is traversed on the way to the meditative goal. Sometimes this period is referred to as the stages of dukkha nana, knowledge of suffering, or the stages of the dark night, though this is not to be confused with St. John of the Cross's term. Just to highlight some important examples, though these are not in order, Bhaya Nana, as implied by its name, is often characterized by fear, hypervigilance, and sometimes physical pain. Some meditators describe hypervigilance to the extent that ordinary objects become frightening. Another stage, Bhanga Nana, or knowledge of dissolution, is characterized by perceptions of vibration, shaking, and decay. Meditators have described the feeling that not even the ground they stand on is solid. This can be very scary for some people. It is interesting, however, that this is not just seen with Vipassana practice. Castillo interviewed a number of mostly long-term transcendental meditators, and some described vibrations and things melting at times over the course of their practice. These were high-functioning, employed, well-educated individuals who reported no impairment from these experiences. For example, Mr. F., a 43-year-old master's degree holder, described seeing that objects are not solid. They're like millions of little spots, and boundaries between objects are more fluid. They're less defined because the object itself seems to be moving. This effect was also seen in an experimental setting where people were instructed to stare at a blue vase for 30-minute sessions. And as an example, G, at the 60-second session, described things seemed to sharpen and there was a different nature to the substance of things. It's as though I'm seeing between molecules. The usual mass of solidity loses its density or mass and becomes separate. Also included in descriptions of Vipassana practice are experiences of cognitive splitting, where the meditator describes a sense of observing, as if from the outside, the procession of thoughts and mental images. This form of a detached observation, like an observing ego stance, enables one to perceive a mental object and its concomitant emotion as separate, distinct entities. Among many Hindu yogic practices, these senses of splitting are viewed favorably, in line with the ultimate goal of unity. Castillo surveyed 5 meditators who had been practicing TM anywhere from 1 to 15 years. All were high-functioning people, again successful in their careers. None reported any psychiatric history, but all endorsed dissociative experiences in relation to their transcendental meditation practice. The duration of their dissociative experience varied. 3 reported continuous dissociative symptoms from 1 year up to more than 3. 2 described frequent symptoms that are ongoing, and 1 reported a remote single episode. All reported no current functional impairment, again, from these experiences. There are a couple cases of meditators seeking medical assistance for these dissociative symptoms, but it appears that support, whether from a teacher or therapist, seemed to be the main treatment. In one case, being told that this was a normal part of meditation by a guru was enough for the patient to improve. Depression is sometimes described as worsening by meditators. One meditator reported in Lomas 2015 a crushing experience of despair. You just don't feel like you exist. There's nothing really there. It's nihilistic and pretty terrifying. Suicidal thinking after meditation is not a new concept. In the Tipitaka, the doctrinal foundation of Theravada Buddhism, it records that many monks committed suicide after meditating on the human corpse in states of decay. Lazarus documented a suicide attempt by a woman after a weekend transcendental retreat and reported he was aware of several cases of meditators describing worsened depression with their practice. Most reports of suicidal ideation in patients who had been meditating occurred in the context of psychosis. Highlighted are the diagnoses they received at the time. Euphoria is another well-known potential experience associated with altered states of consciousness during meditation. It has been described as a component of Satori in Zen, as part of the first stages of Chana, and described in St. Teresa's Devotion of Union and Devotion of Ecstasy. Tapa and Murti compare the subjective accounts of altered states of consciousness in subjects with complex partial seizures, schizophrenia, and meditators from ashrams and other religions in India. Perceptual distortion in altered states was common to all 3 groups, but only meditative altered states were accompanied by a positive emotional effect. Meditation is known to have effects on the right temporal lobe, an area associated with euphoria and mania. Changes are known to occur in cerebral blood flow distribution in the prefrontal and parietal cortex, and serotonin may also be increased during meditation. Other potential mania precipitants may be encountered during meditation, including dealing with difficult emotions and stressful life events. Often people seek out meditation when facing a significant stressor. Additionally, adopting a radically different lifestyle, such as in a retreat setting, can also be a significant stressor and potential trigger. The sparse reporting of mania in case report, despite what would seem a predisposing factor in well-described euphoric events in meditation, led Yorston to muse that adequate practice and supervision may enable the subject to learn to control the emergence of interpsychic material. We see in several case studies that meditation may act as a trigger for manic or psychotic episodes in people with prior history of depression or bipolar symptoms. I highlighted the rows indicating prior diagnosis and diagnosis at or after the episode. However, it's very important to note, as did researcher Willoughby Britton, that many people with prior existing mental health diagnoses are able to participate without difficulty and often benefit from even intensive meditation practice. She suggests that an issue is not so much identifying those at risk as it is improving support systems. Perceptual disturbances are a known classic phenomenon in meditation. When in certain states, the meditator may see lights, hear sounds, or feel unusual sensations. A study at Brown University interviewed 28 meditators practicing Vipassana, Tibetan, and Zen Buddhist traditions. Half were meditation teachers. 9 reported experiencing light phenomenon, with an average of 5 years practice before these experiences arose, half in retreat settings. What is interesting is that these experiences were seen only in the more advanced meditators, and mainly during intensive practice. Some traditions describe the possibility of experiencing disturbing, even frightening mental images. These can include visions of death and rotting corpses. This may be viewed as an opportunity to better understand the nature of reality. However, as pointed out by Fra Mahabua, a monk from the Thai forest tradition, some people, especially if they have an anxious or fearful disposition, can be harmed if they pursue these images and even be driven mad. In Zen, potentially terrifying experiences in Zazen are called makyo and are described as a mixture of the real and the unreal, not unlike ordinary dreams. They can be visual or auditory and encompass anything such as demons or sounds of explosions. Students are instructed not to consider these as real or having any meaning whatsoever. Meditation and sensory deprivation have been described as having parallels, as both involve temporary withdrawal from stimuli without loss of consciousness. It has been suggested that singleness of thought, such as in concentration meditation, may produce hypnagogic imagery, kinesthesia, and hallucinations. Meditation cannot always be distinguished from hypnagogic sleep on EEG, though REM is not seen in the meditative state. In even the first study on sensory deprivation performed in the mid-1950s, some of the subjects reported visual hallucinations, including light flashes, geometric patterns, figures, and dreamlike scenes and sounds, such as rows of little men with black caps on and their mouths open, or the feeling of being hit in the arm by pellets fired from a miniature rocket ship. Here's a list of case studies of episodes of brief psychosis after meditation. The actual diagnoses here are variable given changes in DSM criteria over time, but also variations in diagnostic criteria internationally. What is important to note is the actual duration of these episodes. I did not include Qigong deviation or psychosis on this slide, as that may be considered more of a culture-bound syndrome. Some have suggested that these types of symptoms could be from the emergence of psychotic defense mechanisms in response to onslaught of internal experience that can occur with meditation. However, there's also evidence suggesting neurochemical changes, specifically dopamine, may be occurring. Dopamine is thought to play a role in religious experiences given increased activity in the dopamine receptor-rich caudate nucleus, though not to imply this could be reduced to just this. Some meditators have reported uncontrollable movements in limbs reminiscent of EPS, and some reports describe stereotyped facial movements that we normally only see in extreme mania. An in vivo study using 11C raclopride PET scans showed increased endogenous dopamine release in the ventral striatum during yoga nidra meditation. In the striatum, dopamine modulates excitatory glutaminergic synapses of the projections from the frontal cortex to striatal neurons, which in turn project back to the frontal cortex via the pallidum and ventral thalamus. Participants underwent 2 scans, one with eyes closed and one during active meditation. The tracer component competes with endogenous dopamine for access to dopamine D211 receptors, predominantly found in basal ganglia. During meditation, there was a 65% increase in endogenous dopamine release compared to the control. The reduced raclopride binding correlated significantly with concomitant increase in EEG theta activity, a characteristic feature of meditation. All participants reported heightened, vivid, sensual, sensory imagery. It was suggested that being in the conscious state of meditation causes a suppression of the cortical striatal glutaminergic transmission. Meditation may amplify loosening of conceptualization in individuals with certain personality disorders, such as schizoid personality. Many forms of meditation encourage a non-attached approach to the world, including biologic drives and cravings. This may prove problematic for someone who is already withdrawn or struggling with daily responsibilities. However, there are a number of studies that raise the possibility of overlap in diagnosis of personality disorder and schizophrenia spectrum disorders diagnosed later. The age at which patients demonstrate a psychotic episode is, for many of these cases, within the range we would expect a first break in someone who would later go on to have schizophrenia. It's very possible some of these personality diagnoses actually represent prodromal schizophrenia, with the meditation practice either coincidentally coinciding with the first episode or being a precipitant. And I highlighted ages and diagnosis there. There are a number of papers looking at meditation, specifically mindfulness as a treatment for psychosis, and has shown some encouraging reduction in actually negative symptoms. One study, though, in the Netherlands in 2013, where researchers explored use of mindfulness in patients recovering from a first psychotic episode, and where patients were taught a mixture of meditation techniques twice a week for 1 hour each for a total of 8 sessions. 13 of the 16 completed the course. 2 patients were lost to follow-up, and while none of them showed increase in psychotic symptoms, and there may have been some benefit in sleep and affect, one participant had some significant difficulties. They described this as he misunderstood the mindfulness instructions, but he had really significant distress and depression symptoms emerging after doing this. People with a known history of schizophrenia diagnosis have been reported to have had psychotic episodes after engaging in meditation. The time spent doing the meditation practice appears to be relatively short, but almost all of these patients were engaging in intensive practice. Other frequent factors are sleep deprivation and fasting prior to these episodes, raising the question, is it the meditation that's triggering the episode, or the known triggers of sleep deprivation and fasting you see in a retreat, or some combination thereof? Among the cases, some stand out for the apparent temporal correlation of meditation and psychosis in some patients. Sharma 2015 described a patient who became psychotic after meditating, got better when he started medications and stopped meditating, and then his symptoms returned 2 to 3 weeks after he resumed his meditation practice. Cheryl et al. 2016 described a patient that developed mania and psychosis 3 times after engaging in meditation. It is important to note that episodes of psychosis and mania were not generally reported with practices like mindfulness or loving-kindness meditation. Concentration meditation, especially when engaged in intensively, seems to be the most frequent technique represented in these reports. Bhikkhu Kantipalo described in his publication, Practical Advice for Meditators, it is through straining or forcing meditation practice that many emotionally disturbing states arise. Sudden bursts of intense anger all over insignificant trifles, fierce cravings and lust, strange delusions, and even more peculiar fantasies can all be produced from unwisely arduous practice. There are some potentially confounding factors that we should take note of in these case studies. Apart from the prior history of psychosis, there's also concurrent sleep deprivation, fasting, history of illicit drug use in some cases, but also cultural context. It is often difficult to separate meditation and culture. Castillo reported that meditative states among Indian yogis are often characterized by dissociation and hallucinations. However, these experiences are not necessarily labeled as pathologic in Eastern meditative traditions, though it can be in certain situations. In India and China, for example, there are clinics focused mainly on adverse reactions to yoga and qigong, respectively. Groff and Groff had argued that traditional psychiatric diagnostic thinking fails to recognize the differences between psychotic experiences and potentially helpful mystical experiences that they termed transformative crises. Differentiating between common effects of these practices, culturally accepted variations, and psychopathology can be difficult. The DSM-5 warns that cultural concepts and variation can cloud the clinical picture, leading clinicians to either misjudge the severity of a problem or assign the wrong diagnosis, such as psychosis. Further complicating the picture is that cultures are open, dynamic systems that can easily be overgeneralized or stereotyped. And what about these patients who are practicing meditation techniques originally derived from other traditions or cultures? There may be complex cultural interactions that haven't been examined. Often the general public is not aware of the religious or cultural origins of a specific meditation practice and will pick it up for stress reduction or health benefits. One group of researchers cautioned physicians that interaction with an experienced guide is in general preferable to indiscriminate use of medication. Second, while often clinically psychosis-like, these are distinct entities from functional psychoses. Nathan Fisher, who worked with Willoughby Britton on the Dark Night Project, suggests that there are two categories of difficulties in meditation practice: those that result from incorrect or misguided practice that could be avoided, and experiences that are considered necessary and expected in the traditions in which they are practiced and derived. The most important takeaway from today is that meditation is a tool, intrinsically neither good or bad. It can serve to be very beneficial in a constructive way, but also the potential to be destructive if not handled properly. If we are to use a meditation-based therapy in a clinical setting, such as mindfulness, familiarity with the origins of that particular method is recommended in the event the patient encounters difficulties. General understanding of the origins of meditation, cultural interpretations of these techniques, and anticipated results is needed to reduce misdiagnosis and prevent misunderstandings. It may be helpful to elicit the patient's own understanding of what is happening. In the style of cultural formulation interview, perhaps regardless of whether the patient identifies with a cultural or religious group that practices meditation, the CFI had been used before to resolve uncertainty and psychotic diagnosis in patients from a diverse background. And the open-ended format that it presents can be extremely helpful in determining if meditation experiences represent pathology. So briefly, as mental health providers, an awareness of a patient's personal practice of meditation and alternative therapies can be very helpful. Lou and Pierre actually recommend screening patients for the use of these techniques, including yoga, as well as assess cultural context. If using mindfulness techniques with patients, I do want to stress additional caution should be given for patients with history of psychosis, if these techniques are to be used with that population at all. As we have seen, there have been some studies supporting the use of these techniques with such patients, but given the apparent temporal association of meditation and psychotic episodes seen in some individuals, special care is warranted. Recommendations have been proposed to reduce risk, such as using only experienced instructors, brief sessions in small groups with the possibility of one-on-one discussion, and lastly, avoid explicitly analytical or insight-based techniques, as these have been known to be stressful even for healthy people. So what can we tell patients if they want to try meditation, or if we're interested ourselves? It's considered safe for most healthy people when practiced for a limited time daily. I would advise a caution again for history of mood or personality disorder or history of psychosis, given that you may see initial worsening of psychiatric disease with these techniques. As a general guide, 20 to 30 minutes a day is considered both beneficial and less likely to create unwanted effects. The Transcendental Meditation Program, which is one of the most of the research techniques, recommended participants limit their meditation to 20 minutes a day and follow up with a trained instructor. Benson noted that patients practicing meditation for only 20 to 30 minutes a day generally didn't experience problems, but with more intensive practice, he did observe occasional difficulties. The available case studies tend to support this. Though we don't know if the more intensive meditation practice is causative. Having a competent meditation teacher is strongly recommended, especially if doing more intense or advanced practices. Alan Wallace once stated that in the 35 years he has been involved, he has encountered a number of people who ran into psychological problems during meditation, but it usually occurred when they were not practicing under an experienced teacher. He said, if one is meditating 10 or 15 minutes a day, the chances of damage are small. If you push that up to 10 or 12 hours a day, you will want some very skillful guidance. Okay, so I know there's a couple meetings that are going to be starting soon, so if anybody needs to leave at this point, you're absolutely welcome to. I do have one case that I actually had myself in an outpatient clinic for anybody that wishes to stay. It'll probably just take a couple minutes. So a middle-aged man came into the office and stated he had stopped using recreational alcohol and opiates, as well as his prescribed fluoxetine. When asked about this change, he states that he had taken up meditation after learning about it in some class at a community wellness group. He denied any feelings of depression or anxiety anymore and attributed his past 6 months of sobriety to meditation. He doesn't know the name of the technique he's using, but describes watching the movement of the breath in the abdomen. He initially states he was doing really well and felt like meditation, quote, saved his life. However, in the past 2 months, he does admit he has noticed some problems. He says that he has started to see objects vibrating, and at times the walls and other objects appear to melt and dissolve. Sometimes it feels as if the ground he is standing on gives way and that nothing is solid. He finds this distressing, but denies that he has talked about it with anyone. When asked if something had changed, he states that he increased his time meditating from 2 to 3 hours a day the past 3 months. He has an otherwise unremarkable mental status exam, and when asked if he had someone giving him instructions on this technique, such as a teacher, he states the wellness class was just temporary. He says he does have support from some of the other people who took the class, but doesn't know if they've had similar experiences because he's been embarrassed to talk about this. He describes that he had been able to continue his daily activities and take care of responsibilities despite these recent concerns. So how would you treat this patient? Any takers?
What you could do is put him in contact with the instructor. Just first of all, assure him that based on your research, this is a normal trajectory for what he's experiencing, and let him know he's not going psychotic. And then maybe find him resources that can help him develop his practice because it seems to be benefiting him, but also kind of take away the negative aspects of it.
Any others?
I think he should have antipsychotics. And I have another, as you were talking, I was thinking about how this is sort of the legacy of imperialism in a way, or the legacy of cultural appropriation of these traditions by a culture that is very much attached to outcome. You know, and the slide where you showed the two people in scrubs, you know, sitting in Sukhasana, they really should have had blankets under their hips, but I think it's very difficult for Americans to think about these practices without thinking about what we could get out of it. You know, whether it's, you know, my kid's going to be smarter or, you know, whatever the outcome is. And so I think going along with that is our attachment to certain mental states. So that we, you know, when people think about meditation, they're like, oh, yeah, I want to relax. I want to get enlightened. And they don't consider the possibility that it's not really about producing a state.
Yes.
It's about experiencing a state. So I think it's important to start talking about these practices not as a big glob of, you know, anti-anxiety, you know, methods, but starting to like prioritize them in terms of what kinds of practices are more potentially dangerous.
Right.
And I think that goes for the movement practices as well as meditation. And so I think this is a really, this particular case is an example of somebody who's going for it with meditation. And I don't think it's at all healthy. And I don't know if it's possible to practice with that intensity in this cultural context and not be taking a lot of risk.
Just for this particular case, did you ask the patient that what was the reason that he went for the 3 hours? Was it any symptoms left?
Yeah, he felt that it was helping with his cravings, like his addiction cravings, and also his mood. And so that he felt that was the reason he was able to go off of these medications.
Well, as usual, when we treat the patient even with the medication, sometimes when they have a residue of the symptoms, they think that if they take more of that medication, they may be better, and they go on. And the same thing goes with the mindfulness and everything else. So I think that reducing the dose of the mindfulness may be an option for those kind of the patient.
Yeah.
First of all, thank you for this really well done and informative presentation. I'd like to take a different tack on your questions here, because in the same way that there was a comment about sort of cultural imperialism, I see the questions as also having a cultural context. The question of how would you treat the patient leaves the patient out of the decision. Where's the partnership? What does the patient want? And so I think that's a question that comes from a particular stance and attitude on the part of clinicians that is itself potentially a problem.
Right.
And then likewise, would you prescribe an antipsychotic? That is a question that comes straight out of the pharmaceutical industry playbook. They want you to think about that question. And again, it's what does the patient want? With respect to the specific issue that was mentioned about dealing with addiction cravings, I think the case raises an interesting question as to whether or not medication itself can be something that is experienced addictively. And I seem to recall seeing in the literature that issue actually being discussed by practitioners and teachers who talked about certain individuals who got into this and then literally related to it as if it was an addiction. They needed more and more of it. They experienced withdrawal when they didn't have it and so forth. So it may be that he simply substituted one addiction for another.
All right. Well, I am, absolutely.